By the time that first tremor shows up, the exact moment that sends most people to a neurologist for the very first time, the underlying biological process driving that tremor may have already been quietly unfolding for 10 to 20 years. And by that same moment of initial diagnosis, roughly 60 to 80% of the specific dopamine-producing neurons responsible for smooth, coordinated movement are already gone. 60 to 80% vanished before the first noticeable symptom even appeared. This is the defining truth about Parkinson's disease that very few people are ever told during their first doctor's visit. The visible signs, the shaking, the muscle stiffness, the slowed movement, do not mark the beginning of the disease. They mark the threshold where the brain can no longer make up for the damage inside. Today, I'm going to walk you through every single stage of Parkinson's disease, including the hidden stage that occurs before any official diagnosis can even be made. We will explore what is happening inside the brain at each step, what the person physically experiences, what family members and caregivers face alongside them, and what each phase requires in terms of future decision-making. Here's the critical statistic that puts all of this into perspective. Parkinson's disease is currently the fastest-growing neurological condition on the planet. That alarming finding was published in JAMA Neurology back in 2018 by researchers tracking 5 decades of global health data. Over the past 25 years, the number of individuals living with Parkinson's has more than doubled. Right now in the United States, roughly 1 million people live with the condition, with nearly 90,000 new diagnoses handed out each year, a 50% jump compared to estimates from less than 10 years ago. Parkinson's isn't rare, it is widespread, accelerating, and severely underrepresented in broader public health discussions relative to its true impact. Understanding how this disease progresses matters deeply, not just for those living with the diagnosis, but for the family members and caregivers standing by their side. Most patients are handed a diagnosis without ever receiving a clear roadmap of what lies ahead. This video serves as that roadmap. Make sure to subscribe now to help Dr. William Lee deliver these crucial medical explanations to the families who need them most. The most limiting misconception about Parkinson's disease is treating it purely as a movement disorder defined by a hand tremor. While a tremor is certainly one of its most obvious symptoms, Parkinson's is actually a complex neurodegenerative condition that impacts far more than physical motion. It affects sleep quality, mood stability, cognitive processing, digestive health, blood pressure control, and even your sense of smell, frequently years before any shaking begins. Why is this distinction so vital? Because the very earliest warning signs of Parkinson's are not movement-related at all. They are non-motor symptoms, subtle shifts in gut function, sleep patterns, emotional health, and sensory perception that can precede physical motor symptoms by years or even decades. If we continue viewing Parkinson's solely as a shaking disease, we will consistently miss the chance to catch it early, long before the majority of critical brain cells are lost forever. By the end of this video, you will fully understand all 5 clinical stages of Parkinson's disease, what occurs within the brain during each phase, the patient experiences day to day, and what the surrounding family goes through. I will also guide you through the crucial period that occurs before all 5 stages, stage 0, or the prodromal phase, where the disease builds silently before a formal diagnosis is possible. If you or someone close to you has recently received a diagnosis, this guide will provide a clear, honest framework for what to expect, cutting through the vague generalizations that usually follow an initial appointment. If you are watching on behalf of a parent, partner, or loved one, this information will give you the vocabulary and insights needed to advocate effectively for their care. I also want to address a reality that this channel discusses in depth. Between 50 and 80% of people diagnosed with Parkinson's disease will eventually develop dementia as the condition advances. We will cover this explicitly in the later stages because families deserve to understand this trajectory long before they are forced to navigate it unprepared. Let us begin before stage 1, where the disease actually takes root. But first, let's spend 2 minutes on the core biology, because understanding the underlying mechanism makes everything else clear. Parkinson's disease stems from the loss of specialized neurons in a small, deep brain region called the substantia nigra. The name translates from Latin to black substance, because in a healthy human brain, this area appears distinctly dark due to a pigment called neuromelanin made by these cells. In a brain affected by advanced Parkinson's, this region looks noticeably pale upon autopsy because those dark neurons have died off. These neurons produce dopamine, a key neurotransmitter that travels from the substantia nigra, the striatum, allowing for smooth, fluid, and coordinated muscle control. When dopamine levels plummet due to cell death, physical movement breaks down, becoming slow, stiff, imprecise, and difficult to initiate. What drives these neurons to die is the accumulation of abnormal protein clumps called Lewy bodies, the exact same alpha-synuclein aggregates we examined in our video on Lewy body dementia. As Lewy bodies gather inside these cells, they disrupt normal cellular processes and eventually trigger cell death. Here is the key takeaway regarding timing. The human brain is remarkably resilient and compensates for early damage. As neurons start dying, the surviving cells work harder and more efficiently to keep things running smoothly. Dopamine is recycled more effectively, and alternative neural pathways are activated. The brain effectively hides this ongoing cell loss for years. By the time compensation finally fails and a noticeable tremor brings a person to a doctor, 60 to 80% of those vital neurons may already be gone. The disease has been silently building in the background for a decade or longer. That is precisely why stage 0, the phase before diagnosis, is so remarkably important. Stage 0 is the prodromal phase, meaning it precedes the main clinical symptoms. In Parkinson's disease, this silent phase can span 10 to 20 years before a single movement issue appears, and it is far from symptom-free. It carries its own distinct set of non-motor warning signs that medical science now recognizes as the earliest flags of the condition. The first sign is anosmia, or the loss of the sense of smell. We are not talking about temporary congestion from a cold or seasonal allergies, but a persistent, gradual loss in odor detection with no obvious explanation. Research indicates that anosmia occurs in up to 90% of Parkinson's patients, often showing up years before any physical shaking. Many people simply dismiss it as a normal part of getting older and never mention it to their doctor. The second sign is chronic constipation. This is persistent, treatment-resistant constipation that represents a sudden departure from a person's normal gut habits without any obvious dietary cause. Groundbreaking research by Dr. Heiko Brock established that Parkinson's pathology, specifically those alpha-synuclein aggregates, may actually originate in the digestive tract before traveling up nerve pathways into the brain. Constipation as an early predictor of Parkinson's has now been documented in numerous large-scale clinical studies. The third sign is REM sleep behavior disorder. During normal REM sleep, your body enters a state of temporary muscle paralysis to keep you safe. In REM sleep behavior disorder, that safety mechanism breaks down. The individual physically acts out vivid dreams, talking, shouting, or kicking and punching, which can accidentally injure themselves or their bed partner. Studies led by Dr. Ron Postuma demonstrated that REM sleep behavior disorder precedes Parkinson's motor symptoms in a vast number of patients, sometimes by 10 years or more, making it one of the most accurate early indicators of the disease. The fourth sign is unexplained depression and anxiety. Unexpected shifts in mood regulation represent a recognized non-motor feature that reflects early disruptions in dopamine and other brain chemicals, long before physical movement is impaired. Do not view stage 0 as a theoretical concept. These are real daily symptoms that people live with for years before a specialist connects the dots to Parkinson's disease. Someone experiencing a lost sense of smell, persistent digestive issues, and a bed partner reporting nocturnal kicking and screaming may well be in stage 0 of a condition that won't be formally diagnosed for another decade. If multiple prodromal signs are present, especially the combination of loss of smell, constipation, and dream enactment sleep issues, scheduling a consultation with a neurologist is a wise and worthwhile step. Stage 0 is the disease operating without a label. Stage 1 is where it finally becomes clinically observable. Stage 1 represents the earliest clinical phase of Parkinson's disease, evaluated using the Hone and Yahr scale, the gold standard staging tool introduced in 1967 and still relied upon today. Stage 1 is defined by symptoms that occur exclusively on one side of the body. If a tremor is present, it appears in just one hand, arm, or leg. Not both, just one side. Muscle stiffness and slowness of movement, known medically as bradykinesia, are similarly unilateral. The classic resting tremor, which eases during intentional activity and returns when the limb is relaxed, is the hallmark symptom most people expect. However, about 20 to 30% of people diagnosed with Parkinson's never develop a tremor at all. Not every patient experiences shaking. Other subtle stage 1 changes that loved ones often spot before the patient does include a reduced arm swing on one side while walking, a slight reduction in facial expressiveness, making the face look less animated, a symptom known as hypomimia, a softer, quieter voice known as hypophonia, and changes in penmanship where handwriting becomes tiny and cramped, known as micrographia. Day-to-day life during stage 1 remains largely intact. The individual can still live independently, maintain employment, drive safely, and manage daily responsibilities. While the symptoms are noticeable, especially to close friends and family, they do not yet cause significant physical disability. The primary hurdle during stage 1 is securing an accurate diagnosis. Because the early symptoms are mild and limited to one side, patients and physicians frequently attribute them to pinched nerves, joint overuse, or routine aging. Research shows the average delay from initial symptom onset to formal diagnosis exceeds a full year. That delay matters, not because existing treatments reverse underlying damage, but because it postpones setting up a care team, implementing supportive lifestyle changes, and beginning the forward planning that stage 2 will soon demand. Stage 1 affects one side of the body. Stage 2 marks the point where the disease crosses over the midline. In stage 2, physical symptoms spread to both sides of the body. The tremor, rigidity, or slowness that was previously isolated to one side now affects the opposite side as well. General movement becomes noticeably slower. Routine tasks that used to take 30 minutes may now require 45 or 60 minutes. This slowing is consistent and cumulative. Facial expressiveness continues to lessen, and the voice grows softer. Family members notice that a vital channel of physical expression has dimmed, not the person's core personality, but the physical mechanism through which that personality is conveyed. A face that once smiled effortlessly now takes deliberate exertion to animate. Postural shifts also become apparent, such as a slight forward lean or stooped shoulders. Footsteps may transition into a shuffle rather than a clean stride. And turning around, rising from a chair, or stepping forward from a standstill all require conscious focus. Crucially, balance remains fully functional in stage 2. The individual can still catch themselves if they stumble. They can continue living independently and handling daily chores, albeit with extra effort and at a more measured pace. Non-motor symptoms that started in stage 0, such as sleep disturbances, constipation, mood changes, and mild cognitive slowing, frequently intensify in stage 2. Unfortunately, these non-motor issues are often overlooked in appointments because clinical visits focus primarily on physical motor symptoms, which are easy to observe and measure. Yet for the patient, the non-motor burden in stage 2 is often far more challenging than the physical slowness. Stage 2 still allows for independent living. Stage 3 is where that independence encounters its first major threat. The key clinical milestone separating stage 2 from stage 3 is impaired balance, specifically postural instability. The person can no longer reliably regain their footing after an unexpected bump or loss of balance, causing falls to become a real hazard. While falls might not occur constantly in early stage 3, they happen frequently enough to become a major clinical worry and a primary safety concern. Neurologists assess this using the pull test. Standing behind the patient, the clinician gives a quick, firm tug backward on the shoulders. A healthy person, or someone in stage 1 or 2, takes a single step back to catch themselves. Someone in stage 3 will take multiple unsteady steps backward or tumble completely if not caught. The automatic balance, reflexes we rely on to prevent falls, no longer function properly. Falls in Parkinson's disease are far from trivial. They represent one of the leading drivers of hospitalization and severe injury. The combination of slow reactions, muscle stiffness, and lost balance reflexes means that when a fall begins, the body simply cannot move fast enough to protect itself. A hip fracture in stage 3 isn't just an orthopedic injury. It fundamentally alters the entire trajectory of care. While an individual in stage 3 remains physically capable of handling most daily self-care tasks and can still live alone with proper precautions, the risks are significantly higher. Driving capabilities must be carefully reassessed at this point, as reaction speed, spatial judgment, and emergency response times are all compromised. For caregivers, stage 3 is the moment where home safety adjustments become urgent necessities. Installing grab bars, using shower chairs, clearing trip hazards, and adding non-slip flooring are essential interventions that prevent the severe injuries responsible for rapid functional decline. Stage 3 still permits a degree of independence. Stage 4 brings that independence to an end. Stage 4 marks the transition from challenging independence to clear dependence on others. While the person may still stand or walk short distances, often relying on a walker or mobility device, they can no longer live safely without assistance. The physical demands of daily life now exceed what the disease allows them to manage alone. Dressing, bathing, meal preparation, and tracking medication schedules all require hands-on help. Falls become more frequent and far more dangerous. Non-motor symptoms escalate substantially in stage 4. Sleep fragmentation becomes severe, constipation may require aggressive medical intervention, and blood pressure control collapses into a condition called orthostatic hypotension, where blood pressure drops sharply upon standing, inducing dizziness and compounding the fall risk. Chronic pain, profound fatigue, and anxiety are widespread. Additionally, cognitive decline becomes a central clinical challenge in stage 4. I want to speak directly about a reality many families are never clearly told. Parkinson's disease dementia affects between 50 and 80% of individuals navigating long-standing Parkinson's. Most people in stage 4 display some degree of measurable cognitive decline, and for many, full-blown dementia takes hold in stages 4 and 5. The pattern of cognitive change in Parkinson's differs from classic Alzheimer's disease. Executive function, processing speed, attention span, and visual spatial perception are usually impacted first. While memory is impaired, it doesn't always show the prominent early loss seen in Alzheimer's. Visual hallucinations, the same key feature we examined in our Lewy body dementia guide, are common in stages 4 and 5, often proving deeply distressing for unprepared families. This shared symptom is no coincidence. Parkinson's disease dementia and Lewy body dementia share identical brain pathology, driven by alpha-synuclein Lewy body accumulation. They are deeply intertwined conditions. For loved ones managing stage 4, the critical warning regarding antipsychotic medication sensitivity in Lewy body dementia applies here as well. Standard antipsychotic drugs prescribed for agitation or hallucinations can trigger severe, potentially life-threatening reactions in Parkinson's patients due to their underlying brain chemistry. Any medical provider treating behavioral symptoms in a Parkinson's patient must be fully alerted to this sensitivity before any antipsychotic drug is considered. Stage 4 brings the heavy weight of the condition into every aspect of daily life. Stage 5 is the final phase, requiring the absolute clearest understanding long before families arrive there. Stage 5 represents the most advanced phase of Parkinson's disease. By this point, the individual can no longer stand or walk safely, becoming entirely wheelchair-bound or bedridden. Every single activity of daily living requires full assistance from a caregiver. The physical symptoms that started as a subtle hand tremor on one side in stage 1 have progressed over years into complete physical dependency. The swallowing reflex degrades significantly in stage 5, a condition known as dysphagia. Food, liquids, or saliva can accidentally slip into the airway instead of the esophagus, creating a high risk of aspiration pneumonia. Meals demand specialized feeding techniques, modified food consistencies, and thickened liquids. This mirrors the advanced stage described in our video on dying from dementia, as the underlying neurological breakdown is similar. As the brain loses its ability to coordinate complex muscle sequences, it fails first at the most intricate and recently maintained tasks. Dementia is present in the vast majority of individuals who reach stage 5. Vivid hallucinations, severe confusion, and profound memory loss are widespread, and the person may no longer reliably recognize close family members or communicate verbally. Yet, as I've shared across multiple videos on this channel, incredible glimpses of connection can remain even when so much has been lost. The sound of a familiar voice, a gentle touch, or a beloved piece of music can still elicit a meaningful response. These moments are real. They reflect the survival of the brain's most ancient, deeply rooted emotional networks, which Parkinson's, like Alzheimer's, affects last rather than first. Most people with Parkinson's disease do not pass away from the disease itself. Rather, they succumb to medical complications, with aspiration pneumonia being the leading cause of death, alongside complications from falls and immobility. The official death certificate might not list Parkinson's directly. It lists the physical complications that Parkinson's ultimately made impossible to prevent. This is why advanced directives, formal, written legal documents detailing a person's explicit wishes for end-of-life care must be established during stage 3 or early stage 4, while the individual retains the cognitive clarity to actively guide those decisions. Stage 5 is not the time to begin making those choices. It is the time to honor the choices already recorded. Before we conclude, I want to address the cognitive trajectory directly, as it remains one of the least explained aspects of Parkinson's disease at the time of initial diagnosis. Again, 50 to 80% of individuals living with Parkinson's will develop dementia over the course of their illness. This is not an obscure complication. It is a well-documented, common aspect of the disease's natural history for most patients. The dementia that arises in late-stage Parkinson's shares its core pathology with Lewy body dementia. Both are driven by the toxic buildup of alpha-synuclein Lewy bodies inside neurons. The official distinction between the two conditions comes down to timing. If cognitive decline shows up within 1 year of physical movement symptoms, the diagnosis is Lewy body dementia. If cognitive impairment develops more than a year after established movement symptoms, it is diagnosed as Parkinson's disease dementia. At a cellular level, they represent the same underlying process. Families who aren't warned about this overlap often experience late-stage cognitive shifts as a shocking surprise, as if a second, unrelated disease arrived out of nowhere. In truth, they are observing the advanced manifestation of the exact same neurodegenerative process that caused the hand tremor in stage 1. If you are supporting a loved one with Parkinson's, and this is your first time learning that dementia is a probable part of the journey, our video covering every type of dementia details Parkinson's disease dementia alongside the other major forms. It is well worth watching before stage 4 makes it urgently necessary. While Parkinson's disease currently has no cure, scientific research strongly supports a set of proactive strategies that can meaningfully alter the rate of progression and enhance quality of life across every stage. Exercise is the single most evidence-backed modifiable factor available. High-intensity aerobic workouts, balance routines, strength training, and structured activities like boxing, dancing, or Tai Chi have all been shown in clinical trials to ease motor symptoms, slow functional decline, and support cognitive health. This isn't just a general recommendation. Multiple randomized controlled trials confirm these measurable benefits. Targeted sleep management, particularly addressing REM sleep behavior disorder and nighttime waking, dramatically improves both daily functioning and cognitive resilience. Furthermore, staying socially connected and cognitively active builds what we frequently refer to on this channel as cognitive reserve. Just as in Alzheimer's disease, creating strong neural redundancy through a lifetime of mental engagement provides a vital buffer against the spread of Parkinson's pathology into cognitive brain regions. These strategies aren't cures, but they are powerful tools. In a condition where 60 to 80% of vital neurons are already gone by the time of diagnosis, every strategy that preserves remaining brain function is invaluable. Before you go, I have one question for you to answer in the comments below. Which stage of Parkinson's disease were you least familiar with before watching this video, and which stage best describes the person you are watching this for? Feel free to just drop the number, stage 0 through stage 5. I read every single comment, and your responses directly guide what we cover next. If this video gave you or a loved one a clearer, more honest understanding of how Parkinson's disease evolves over time, please share it with them. Send it to a family member who wants to know what to expect, or to a caregiver navigating stage 3 right now who needs to understand stage 4 before they arrive there. I'm Dr. William Lee. Look after yourself, take care of each other, and I will see you in the next video.